Welcome to our first virtual session of 2025. Today, presenter and author Tyler McKechnie will be discussing his article on intra-abdominal colorectal surgery and very low energy diets for patients with obesity. And in addition to our esteemed editor-in-chief, Rodrigo Perez, we will be having Dr. Ricardo Cohen guest moderating and also presenting.
All right, then. Welcome, everyone. This is the Techniques in Coloproctology virtual session. First of the year, we're going to start off with a very special study. As you all know, the way this works is we'll have one of the authors with recently published a paper in the journal present his data. And then we'll have an expert to discuss a few of the limitations and different points of view and how things could work in real life and what's the data behind it. So today we'll have Mr. McKechnie from McMaster University, Canada. Has published a very interesting paper. I've personally picked it for the virtual session today. I really found it interesting. And as the expert, we'll have Dr. Cohen from the Hospital Alemán Osvaldo Cruz, who is the bariatric surgeon and metabolic surgeon expert. And I'm sure you appreciate what both of them have to say. So thanks again, both of you, for connecting. Thanks to Dina and Emma, who's doing the work behind the scenes. As a reminder, this is going to be recorded, correct, Dina, and will be available at our YouTube channel. So if you're not yet registered, and please sign up to our YouTube channel, because these discussions are actually very interesting, and I've looked at it myself, and I strongly recommend you do so. So Tyler, again, thanks again for the kindness to connect and to share your data. I will let you share your screen and start off with the presentation of your data, and then we'll have Ricardo comment on it, and then we'll have ask questions from the audience. And I'm sure that the people in the audience can make questions through the chat, and me and Dina will try to address them the best that we can. Go ahead. We can see your slides, by the way.
Perfect. Awesome. All right. Hi, everyone. Today, we're going to be discussing, as was mentioned, a paper that we recently published in October of 2024 in Techniques of Coloproctology, titled Preoperative Very Low Energy Diets for Patients with Obesity Undergoing Intra-abdominal Colorectal Surgery. My name's Tyler McKechnie, and I'm a general surgery resident and PhD candidate at McMaster University in Hamilton, Ontario, Canada. And I'd just like to start by acknowledging all of my co-authors on this paper. Without them, this paper would not have been possible. I have no relevant conflicts to disclose. The obesity epidemic is a growing global public health concern, and its impacts are increasingly evident in Western society in particular. And recent evidence suggests that one of those consequences is an increased risk of both benign and malignant colorectal diseases, as obesity has been strongly associated with the risk of developing both colorectal cancer and diverticular disease. What this means is that in our contemporary surgical practices, the patients that are being brought to the operating room for colorectal surgery have increasingly higher BMIs. And this poses a challenge as patients living with obesity are at higher risk of both worse intraoperative and postoperative outcomes, as I'm sure most people on this call are aware. So patients living with obesity undergoing intra-abdominal colorectal surgery tend to have increased operative time, increased estimated blood loss, and are more likely to have minimally invasive surgery converted to open. They're also at increased risk of postoperative complications such as anastomotic leaks, infectious complications, and more. With this clinical challenge in mind, we tried to think of potential solutions that could be studied. Bariatric surgery came to mind as a related field that we might be able to draw upon, given that in the bariatric subspecialty, they manage patients living with obesity almost exclusively. They implement a variety of preoperative measures to get patients as ready for surgery as possible. And one of those measures is the use of preoperative very low energy diets, or VLEDs, which I'm sure a lot of you on this webinar are familiar with through brands such as OptiFast, SlimFast, MediMeal, etc. And in bariatric surgery, these interventions have been associated with decreased operative time, decreased surgeon perceived difficulty, decreased postoperative length of stay. And our most recent data synthesis in this area suggests that there may even be an important signal pointing towards a reduction in the risk of postoperative morbidity with their use. Our local institution also happens to be a bariatric center of excellence in Canada, and so our colorectal surgeons were able to discuss these findings with our bariatric surgery colleagues, and so they actually implemented the use of very low energy diets for patients living with obesity prior to colorectal surgery in 2018, where they started dosing it to all patients with BMIs greater than 30. This, along with the fact that it's a cheap, relatively cheap and relatively available product, made it a feasible intervention for us to try and design a research program around. And so we started, as most research programs do, with a systematic review and meta-analysis of all studies that looked at the use of VLEDs prior to non-bariatric surgery. We identified 13 studies, 4 of which were RCTs. The mean preoperative weight loss with the use of VLEDs ranged from 3.2 to 19.2 kilograms. Adherence was high at 94 to 100% across studies, and adverse events occurred relatively infrequently. However, these studies were at high risk of bias, they were quite heterogeneous, and none of the studies were well powered to look at patient-important outcomes. The second step that we took as part of this research program was to perform a national survey of surgeons performing elective non-bariatric surgery in an attempt to understand whether surgeons across the country in Canada were prescribing preoperative VLEDs, and if they weren't, would they be willing to? Importantly, 80% of respondents to the survey felt that obesity significantly impacted their elective operations. 31% stated that they prescribed preoperative VLEDs to some extent prior to elective non-bariatric surgery, and 78% stated that they would be willing to consider the routine prescription of preoperative VLEDs prior to elective non-bariatric surgery. So essentially, step 1 told us that the current evidence isn't great, and then step 2 told us that this is something that at least some surgeons would be interested in. And so that led to step 3, which is the current study that we're going to be discussing today. And this was a retrospective cohort study in which we looked at our own institutional data to see if there may be an important effect with preoperative VLEDs in patients undergoing colorectal surgery. We designed this study to answer the question, do adult patients with body mass indices greater than 30 undergoing elective intra-abdominal colorectal surgery who received preoperative VLEDs have improved short-term postoperative outcomes as compared to patients not receiving preoperative VLEDs? This was a single-center retrospective cohort study performed at St. Joseph's Healthcare in Hamilton, Ontario, Canada. We included data from 2015 to 2022. The population of interest was adult patients undergoing elective intra-abdominal colorectal surgery with body mass indices greater than 30, and we defined intra-abdominal colorectal surgery as any intraperitoneal operation requiring resection and/or diversion involving the small and/or large intestines. Surgeons whose patients were included in this study started routinely prescribing preoperative VLEDs in January of 2018 to patients with BMIs greater than 30, as I mentioned before. And so patients operated on after this date were included in the intervention group, and patients operated on before this date were included in the control group. To decrease the risk of selection bias, all patients receiving care prior to the implementation of our preoperative optimization program who received preoperative VLEDs were excluded. And similarly, all patients who received care following the implementation of the preoperative optimization program who did not receive VLEDs were also excluded. All patients received perioperative care as per ERAS protocols. And after January 2017, all patients included in this study who are undergoing colectomy and/or proctectomy received mechanical bowel preparation and oral antibiotics. We excluded patients undergoing emergency surgery, palliative surgery, and those without a BMI that was recorded. The intervention of interest was 2 to 4 weeks of OptiFast immediately prior to surgery. The primary outcome was 30-day overall postoperative morbidity, and this was defined as any documented deviation from the expected clinical course within 30 days of the index surgical date, and was a composite of system-specific complications. Secondary outcomes included 30-day system-specific complications, 30-day postoperative mortality, postoperative length of stay, intraoperative complications, and operative time in minutes, amongst others. Descriptive statistics were used to characterize our sample population, and we analyzed our primary and secondary outcomes with multivariable regression models that included the variables that you see listed here. A sensitivity analysis was performed by removing all Clavien-Dindo 1 complications from our regression analyses for the primary outcome. We powered this study using an event per variable of 10. So this means that for every variable that we included in our model, there should be at least 10 outcome events to have an adequately powered and a model that doesn't overfit. So as you can see, we included 8 variables in our model, which meant that we needed to have 80 outcome events. And so if we assumed that 42% of patients with obesity experienced postoperative morbidity following colorectal surgery, which was based on previously published data from our institution, then that meant that we need approximately 190 patients for adequate power. So we ended up including exactly that, and there were 89 patients that received preoperative VLEDs and 101 that did not. These two groups were similar in terms of ages, had similar distribution of male and female sexes, and similar Charlson comorbidity indices. The mean BMI in the VLED group was 3 points higher than the non-VLED group. The most common operative indication in both groups was colorectal cancer, and the two most common operations were right hemicolectomy and low anterior resection. Additionally, 93% of all operations were performed laparoscopically. There were 2 surgeons present in the operating room for 48% of cases in the VLED group and 38% in the non-VLED group. 100% of the VLED group had mechanical bowel preparation with oral antibiotics as compared to only 11% of the non-VLED group. Equal proportions of patients had neoadjuvant radiotherapy across groups, and patients in the VLED group received Optifast for a mean of 3.5 weeks. In terms of our primary outcome of 30-day overall postoperative morbidity, this occurred in 104 patients, corresponding with 38% of the VLED group and 69% of the non-VLED group. Upon performing our multivariable logistic regression, we found that VLED use had an odds ratio of 0.22, and the associated 95% confidence intervals excluded the line of no effect. Higher Charlson comorbidity indices and rectal dissections were also associated, significantly associated, with increased risk of postoperative complications. As per our sensitivity analysis, where we excluded all complications that were Clavien-Dindo 1, again, meaning those that didn't significantly change a patient's clinical care, this still demonstrated that VLED use was associated with a significant reduction in 30-day overall postoperative morbidity with an odds ratio of 0.3 and again, 95% confidence intervals that excluded no effect. When we looked at our system-specific complications, we saw that the significant reductions in overall morbidity were mostly driven by reductions in respiratory, cardiovascular, infectious, and wound complications. Specifically, point estimates across these system-specific complications ranged from 0.16 to 0.23, with associated 95% confidence intervals, again, excluding no effect. Point estimates for gastrointestinal and genitourinary complications also suggested an important benefit in the VLED group at 0.53 and 0.52 respectively, yet there were wide 95% confidence intervals that decreased our confidence in these findings. Regardless, if you do look at the absolute effect sizes across all of these system-specific complications, you could all argue that the majority of these reductions do appear to be clinically relevant. In terms of our other secondary outcomes, postoperative mortality was low in both groups. The VLED use was associated with just over a day shorter length of stay, but wide 95% confidence intervals included the line of no effect. Intraoperative complications occurred less frequently in the VLED group, 9% versus 17%, and there was no difference in operative time between groups. Additionally, patients in the VLED group were less likely to require ICU admission postoperatively or readmission following discharge, again with point estimates of 0.2 and 0.3 respectively. Overall, these data suggest that the prescription of preoperative VLEDs for patients living with obesity undergoing colorectal surgery is associated with a clinically meaningful reduction in overall postoperative morbidity. The number needed to treat for 30-day overall postoperative morbidity was only 3. These benefits were seen across a number of system-specific complications and were seen in intraoperative complications as well. While these data are encouraging, as this is the largest study of the use of preoperative VLEDs in non-bariatric surgery to date, they should only be seen as hypothesis generating given the inherent flaws associated with retrospective studies. Some of those limitations that I'd like to highlight today are first and foremost selection bias, as surgeons may have been unwilling to prescribe older or more comorbid patients preoperative VLEDs, resulting in prognostic imbalance between the patients who did and did not receive preoperative VLEDs. To reduce this risk, we excluded patients with BMIs greater than 30 not receiving preoperative VLEDs after the time period of our preoperative optimization program implementation. Next, we did not have any adherence data because of the retrospective nature of the study, nor did we have any preoperative weight loss data. Previously published data, however, do suggest that the adherence typically ranges, as I mentioned previously, from 94 to 100%, and the preoperative weight loss can range anywhere from 3 to 19 kilograms, which is reassuring. And very importantly, residual confounding may have impacted our regression findings. Examples of impactful preoperative variables that were unaccounted for that may have meaningfully impacted our findings include nutritional status, sarcopenia, and preoperative lab values. Despite these limitations, we do feel as though these data are highly encouraging, and we have since conducted a pilot randomized controlled trial to evaluate the use of preoperative VLEDs in non-bariatric surgery. We recently concluded our accrual of 92 patients in a one-to-one design comparing preoperative VLED to preoperative standard of care. And we're in the process of analyzing these data and then writing our manuscript, which will hopefully be ready to share in the coming months. So stay tuned for that. And with that, I'd just like to say a quick thank you to everyone that tuned in, as well as the Techniques in Coloproctology for having me. Thank you.
Excellent, Tyler. Really appreciate you sharing your data. Before I turn on to Ricardo, I'm not sure if Ricardo's been disconnected.
I'm here.
Okay. You mentioned the trial that you've recently completed accrual. Is that trial specifically focused on colorectal surgical procedures, or is it general surgery overall?
Yeah, great question. So it's all major elective intra-abdominal and orthopedic surgery. And so approximately 40% of patients are colorectal patients, and then the remainder are a mix of general surgery and orthopedic.
Okay. All right. So let's turn it to Ricardo, who's gonna discuss a little bit, a bit of the obviously the limitations you alluded to, and some of his views on how to manage patients prior to a major colorectal surgery in the setting of morbid obesity. Go ahead, Ricardo. Thanks again for connecting.
Great. Thank you, Rodrigo. Thanks, Springer, for organizing this very interesting session. And thank you, Tyler, for your presentation. And I commend you for using people-first language. For people outside the obesity field, treating patients as people with obesity, people living with obesity, is something that is anti-stigmatizing language. And congratulations for using this, because we are fighting against obesity stigma worldwide. I'm the current director of the Center for Obesity and Diabetes at the Oswaldo Cruz German Hospital. I'm the current president of the International Federation for the Surgery of Obesity and Metabolic Disorders. So what can we learn here? First, I have no conflicts of interest. And when I read the paper, I thought to myself, why exactly did they pursue the retro-prepare study? And one of my conflict of interest is Domura's, one of the co-authors, is a very good friend of mine. So this is a conflict of interest. However, I was thinking, why did they pursue this? Because as Tyler showed, they did a systematic review and analysis, and they concluded in that meta-analysis that very low calorie diet or very low energy diet did not achieve difference in post-op morbidity, operative time, and length of stay. So if they did not achieve the endpoints that they desired to very low-calorie diet in non-bariatric populations, why did they pursue the study if the outcomes of their own meta-analysis did not reach the desired outcomes? And they cite a paper, one of the two papers in regarding bariatric surgery and low-calorie diet, dated from 1211, is that the only thing that calls attention is that there's some subjective feeling of an easy Roux-en-Y gastric bypass only, because all the perioperative complications reached no statistical significance. And if we can see here, I can see my slide because I'm covered by this strip. Okay, and if you see here on table 3 on the right side of your screen, there were not significant complications in the patients submitted to very low calorie diet. Actually, a very marginal statistical significance. So the two reference papers there on bariatric surgery did not reach the conclusion that they wanted. So, and they did pursue the study that Tyler presented. But if you look at what we've been doing at IFSO, the International Federation for the Surgery of Obesity, we just published a couple of months ago at the British Journal of Surgery the role of obesity managed medications and weight loss in pre and post metabolic and bariatric surgery. We don't have very robust evidence on when to add medications before or after the operations. That's why we did a consensus, an expert consensus, but we were based on a systematic review of the current literature. What we found is that weight loss or adding medication before metabolic surgery has a lot of controversial data. First, we may have these two papers. I won't enter into details. It's not a bariatric audience, but here, two papers that say that, yeah, and they're newer papers, 2021 and 2022. We can say, yes, pre-op weight loss may influence perioperative outcomes. The statistical significance is not robust to show that, yes, we can do this. And there are other papers, newer papers as well, where pre-op weight loss did not influence perioperative outcomes and only delays the operations. What we did here, this is our 2022 American Society for Metabolic and Bariatric Surgery and IFSO guidelines for the indications of surgery. And we didn't find any data to support insurance mandated pre-op weight loss. And the US, they do this. Some insurance companies mandate pre-op weight loss. And there's no data to support this because we don't have any better outcomes perioperative than 30 days morbidity and mortality. And the decision for surgical readiness, including pre-op weight loss, should be determined by the multidisciplinary team and by the surgeon. So there's no robust data to support this. And after the consensus among 37 or 39 experts, it's hidden here again the strip here, I cannot minimize here, but it's written on the right side, on the right side of the screen, the column. So we don't have no high level evidence to recommend routine use of obesity medication, not even low calorie diet for weight loss before surgery. There's some, of course, specific situations. We deal with patients with BMIs over 70. We deal with patients with preserved ejection fraction, congestive heart failure. We deal with people with huge liver sizes that maybe low calorie diet or obesity medications can add some benefits. But again, I'm highlighting the maybe because we in our institution running a randomized control trial to show if there's any difference of pre-op medication and weight loss in those patients. And one of the questions is always, well, if you add at least 5% of weight loss, what do you achieve in those patients? You achieve benefits in their complications of obesity. So 0 to 5%, we can achieve benefits over hypertension, over hyperglycemia. If we move with over weight loss greater than 15%, we can achieve diabetes remission, decreased cardiovascular mortality, resolution of heart failures with preserved ejection fraction. So that's not interesting for you for non-bariatric surgery, not even for colorectal surgery, because if you have those patients, we're going to do the operation and you're going to refer this to a center like ours that treat metabolic and disorders and obesity. There's some very good positive points in this study. It's a kickoff for more research, as Tyler showed there. They're in the phase of writing their findings on the randomized control trial. Uh, it actually raises the interest on the role of very low calorie diet in that population, and they show a significant reduction of 30-day post-operative mortality with diet. I commend them from the blinded data extraction, even being a chart study, a very well-defined primary endpoint, a standardized intervention with OptiFast, a very comprehensive analysis. They adhere to strobe guidelines, and they had good hypothesis generating secondary outcomes. However, there are some challenges here. First, they excluded patients not receiving very low calorie diet after 2018. So, as Tyler mentioned, some surgeons will not prescribe very low calorie diets, so those patients were less likely to receive the intervention. And excluding those seeker or non-compliant patients, as they don't have adherence data, probably there's an overestimation of the efficacy of very low calorie diet. And there's some temporal differences in patient managements. So probably since 2017, there's the ERAS protocol, there's advances in surgical techniques, there's a change in overall patient care during this period. So this maybe affect the outcomes as well, as they don't have adherence data first. Although in the meta-analysis that group published is from 94 to 100% because it's a very short-term low calorie diet. If you go over 8 weeks, that will decrease to less than 40%. We see this in patients with obesity and all their comorbidities. I was surprised that there's no reported weight loss, because this should be the marker of the benefit of the intervention. There's no nutritional assessment. It's a chart study. It's retrospective. It's, of course, we understand this, and you need a tape to measure the waist circumference. It's part of physical examination. So this would be another very important surrogate marker of decreased abdominal fat and making your operation easier. The data analysis was good. It was a very rigorous data analysis with the Charlson Comorbidity Index and blah, 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 as Tyler showed. However, as he mentioned in his last slides, there are no adjustment for unmeasured, but very important confounders. First, the socioeconomic status of the patients, if the patients were used to physical activities, and mainly sarcopenic obesity. This will make a huge difference in the data analysis. Although he mentioned, but there's a risk of overfitting in this paper, because you're very, very, very close to the threshold of the minimal threshold for the risk of overfitting. And in a small size of 190 patients, maybe the performance metrics were inflated. I'm not saying that they're not unreliable results. However, there's a huge risk for overfitting leading to unreliable results, and we cannot generalize the results achieved. Tyler and his group, they address an important clinical question. The secondary outcomes, such reduced respiratory, cardiovascular, infectious complications, although they were exploratory, they are the basis for future research. I have no doubts that they have a very good protocol that we're gonna see the paper published soon. And there's a lot of opportunities for improvement. So you call in the paper for an RCT and you performed it. And of course, I'm sure that you have data on adherence, nutritional markers, the magnitude of weight loss, weight circumference, because we need to understand the mechanism of how very low calorie diets they work. So if you look at our studies on the mechanism of actions of metabolic surgery, short-term low calorie diets has weight loss independent effects. So patients lose a very small amount of weight. However, they decrease their weight circumference, and they have a huge effect on the metabolic control. So probably having this huge effect on metabolic control will lead you to have better outcomes in your non-bariatric surgical patients. So this is a very important question to be addressed. However, as Tyler mentioned in their limitations, there's a lot of them in this study, and hopefully the RCT will answer most of those questions. Thank you very much. And again, thank you for the invitation.
Excellent, Ricardo. I'm not sure, Tyler, did you want to address any of the issues raised by Ricardo. I have a few questions for you, and while you address them, it's okay.
Okay.
My first question to you, you or both of you actually. Number one is, we always think about the cost benefit of any intervention that we consider in the surgical field. So one of my questions is how expensive this is, and what are the disadvantages of using a very low energy diet for these patients? What are the downsides, or what are the complications associated with, if any? Go ahead.
Yeah, I can start. So first of all, thanks, Dr. Cohen, for going through the paper. I completely agree with everything you said. The limitations are definitely inherent in a retrospective study such as this, and so hopefully we'll address those moving forward. The kind of rationale behind performing the study was probably two-part. The first is that from the perspective of the meta-analysis that we performed, we didn't necessarily think that the data that were out there were very high quality, and so we wanted to address that limitation. And then secondly, the lack of any data specific to colorectal surgery was another motivating factor. But yeah, so we'll see if the eventual trial that rolls out after that study can hopefully help us out a little bit more than this retrospective study, because I totally agree there's limitations with that. In terms of the cost, to your question, Dr. Perez, in Canada, the cost of Optifast or MediMeal is the new product that we've since switched over to over the past year, is approximately $240 per week. And so as of right now, that's going to be covered by the patient. Obviously, within the context of our trial, we provided that product, but yeah, within the clinical care pathway, that would be a cost that would go on to the patient. So that's obviously a barrier that would need to be addressed, I think, for a lot of populations, especially the populations that are at higher risk, as Dr. Cohen had mentioned, like the socioeconomic status, low SES patients and things like that. So definitely another point to look at in the future from a research perspective. Downsides, I'm sure Dr. Cohen can probably speak to this probably a little bit better than I can, but I do know that with the use of VLCDs or VLEDs, one of the main risks is the loss of lean body mass, or LBM. I don't know if there's that risk it probably doesn't necessarily outweigh the potential benefits of the fat loss, but it generally, I think, is around about 10% of the weight loss is attributed to LBM, the rest being to fat mass. And so that would be one thing, especially if you have like a sarcopenic obese patient or something, a patient with obesity or something of that nature. But that can be one downside that I can think of. But Dr. Cohen, you might have better insights into that.
Actually, if your RCT shows that you do not increase the length of stay and you avoid one respiratory complication, the Optifast is paid already, because it's a short-term, very low calorie diet for 4 to 6 weeks. And I can tell you, based on the new anti-obesity medications like tirzepatide or semaglutide, that from 4 to 8 weeks, and we covered this in our consensus, you won't find an important, significant decrease in lean body mass. So I wouldn't be worried about this. And I think that if you prove that one complication, even minor complication, is decreased after very low calorie diet in your trial, probably you're gonna offset the costs of Optifast. So I think it's a way to go. So Rodrigo, I won't be worried about this. However, if you think there's one paper in non-bariatric surgery using tirzepatide for 12 weeks, so that's 3 months. Those patients did not lose a lot of lean body mass, LBM, and in patients with diabetes, they decrease complications. In patients with obesity without diabetes, no effects. There's an RCT, very interesting. I was one of the reviewers at the Annals of Surgery. It's soon to be published. So, Tyler, when you write your RCT, you should look at this one because they address the lean body mass thing, and Eli Lilly is working hard on this because they want to show that their drug do not affect lean body mass. But I'm sure that 4 to 8 weeks, this will have strong data for very low calorie diet won't affect your outcomes because of a loss of lean body mass.
So what you're saying is that the effects of any medication that you use in these patients is through the correction of the metabolic disorders instead of the actual weight
Probably.
loss. So we're probably not very much interested in the amount of weight that they lose,
Oh, no.
instead of the quality and the control of the metabolic
But
disorders.
what Tyler and Aristides Domuras are looking for, they're looking for less complications, an easier perioperative setting. So this is what they're looking for. And I think if they prove this, because the retrospective study, it's it's a level 3 evidence. It's not that robust. But if you prove this in your trial, I wouldn't be worried about lean body mass. It's not an issue at all, and it's cost effective. Even costing 1,500 Canadian dollars for 8 weeks, it's pretty reasonable.
My other question is, I'm sure everyone who's connected here is asking, can I do something to, ease my procedure with any kind of weight loss? And the question would be, how obese does someone have to be for me to consider any kind of weight loss preoperatively that would affect technical issues of doing or performing a procedure in these patients living with obesity, as is the right way to say? Is there a threshold we should
No,
definitely
no,
consider?
we don't have this answer in metabolic and bariatric surgery. We don't have this answer. It's very controversial data. We are running the study. Let's see if people with BMIs over 50 benefit from pre-op weight loss with medication. We're doing this with GLP-1 receptor analog, with semaglutide. But I can tell you that we don't have data to support that any weight loss. Oh, any weight loss. I'm generalizing. If you look at patients with BMIs over 70, if you look at patients with preserved ejection fraction and heart failure, so in those special situations, yes, weight loss may shrink the liver, may decrease intra-abdominal fat, and eventually make the operation easier. However, I'm speaking about extreme obesity, not people with BMIs of 30 or 40. 30 or 40, I'm almost pretty sure that this will make any huge difference.
Yeah, and I think it probably gets to maybe a little bit, bigger or deeper of a question to Dr. Perez in terms of, how we actually quantify obesity. And so I know that BMI is really a poor surrogate marker for that, and obviously including measures, as Dr. Cohen had mentioned, like waist circumference, and into that helps out a little bit. But realistically, probably the best way for us to understand someone's body composition is with imaging, which is a big ask, but that realistically probably gives us the most information. And so, to Dr. Cohen's point, there's really no data, even like in non-bariatric surgery as well, to tell us, at what level of visceral adiposity are we able to, improve the ease of operations and improve perioperative outcomes.
Okay. Any another question, Tyler, would be, so I'm sure after the outcomes of your study were quite interesting, and you running the trial, have you actually implemented VLEDs in the routine practice of patients with BMI over 30, or are all patients eligible to be recruited to the trial? How is it working at your institution?
Yeah, it's a great question. So, firstly, the colorectal surgeons at our institution had implemented this protocol based off of our bariatric protocol in 2018, actually. And so it was, very similar to, what was described in the manuscript in terms of sticking to the VLCD, 4 shakes of Optifast daily, and a couple of cups of vegetables and lots of fluids. And that's been something they've used pretty routinely since 2018, but there wasn't any, formal inclusion criterion for that. It was mostly just related to whether there was a BMI of greater than 30 or not. One of the challenges that we came across when we started the trial was pertaining to patients with diabetes, because as you can imagine, they do present a issue when it comes to managing their preoperative medications when they go from eating a regular diet to sticking to a preoperative VLCD. And so they didn't necessarily receive these medications these interventions as routinely as other patients during the period before the trial. But since the trial, we've developed a relationship with our diabetes nurse educators who are able to essentially walk patients through how to manage their anti-hyperglycemics in that 3 to 4 week period when they're on the VLCDs. And so that's formalized that process for us. And now, for the most part, it's pretty much any patient undergoing, like I said, intra-abdominal colorectal surgery with body mass indices greater than 30 are almost always going to receive at least a couple weeks of VLCD in our institution.
Okay. Ricardo, to you, in a patient who has obviously uncontrolled metabolic disease and living with obesity, what would be your preferred approach preoperatively to a major surgery? Or if I send you a patient that required a major colorectal surgery for you to deal with it, how would you approach in the light of the new medications that are now available to these patients? That's my first question.
If you refer a patient with diverticulitis, for example, for a colectomy or even a cancer with uncontrolled metabolic disease, our endocrinologist would take your patient, plus the multidisciplinary team, the nutritionist, dietary changes like low-calorie diet, and drug intervention, probably semaglutide or tirzepatide. That's a dual hormonal agonist. This what we would do. And if the patient is uncontrolled in his or her glycemic control, severe diabetes, we have no issues on adding insulin pre-op to have that patient's control with their A1C at least below 9%, because we know in bariatric surgery, so this is the same probably in non-bariatric surgery, an A1C below 9, it does not increase the complication. So we would have the patient who's glucotoxic, A1C over 9 or 10, get it below 9, add him some weight loss, at least 5% of total body weight loss, and then refer back to you for the elective operation. This is what we do.
And what would be the deadline for that to be achieved? I mean, imagine a patient with an early cancer is not, is not the end of the world. There's no big rush, but also it can't be in 6 months. It needs to be within a sensible time period. What would be your, deadline saying, this is it? We can do for X amount of weeks, X amount of months. How would you approach that?
We would do 8 to 12 weeks of drug treatment.
Okay.
So because 8 to 20, it's the average response of at least 5% of total body weight loss with semaglutide and tirzepatide.
Okay.
If you look for diabetes, the same. In 30 to 40 days, we see a change of A1C. So 4 to 6 weeks for people without glycemic control.
Dr. Cohen, if you have patients who are referred who have a benign condition like diverticular disease, how often are you doing bariatric surgery on these patients before their operative intervention for something like diverticular disease, or do you do that at all?
If I understand the question, if you perform bariatric surgery before the colorectal operation for diverticulitis, we don't have a great experience. I can tell you that I can count in my 2 hands, and we did, and the outcomes were pretty favorable for the colorectal operation.
Mm-hmm.
So in a benign disease, it wouldn't be out of a question of doing before the index surgery, bariatric surgery, in order to achieve optimal metabolic control and weight loss, and then do the primary colorectal procedure or whatever.
However, in the past 2 years, Tyler, with the new drugs, that's why we're not getting referrals. And the same happens with massive abdominal hernias. We used to do a lot of bariatric surgery before the hernia repair. We have in our floor, in Rodrigo's floor, in my floor, in the hospital, a worldwide famous expert on hernia surgery, and he used to refer me at least 20 patients a year to do the bariatric operation before the hernia. Now with the new drugs, that decreased half, 10 of the patients. And those 10 who did not respond to medication or they couldn't afford the medication. So,
Right.
medications, they work,
Right.
and they work well. Yeah.
That makes sense.
Tyler, in your randomized control trial, how long do these patients take a very low energy diet? And does it matter the baseline BMI or anything else that how you select patients for longer or shorter periods of time for very low energy diets?
It's a great question. So we struggled a lot with that question when we were designing the trial, because one of the aims of the study was we actually wanted to make sure we were including patients with malignant diseases, to see if there was any potential downsides associated with the use of these interventions in these patients. And as you know, when patients do come in with a colorectal cancer or any sort of malignancy, there is a bit of a timeline on when they do get their operative intervention. And so in Canada, it's generally speaking, the surgeon has 28 days from the time that they receive the referral to the time that they operate on the patient for definitive management of their disease. And so that left us with a pretty small window. And so we actually ended up deciding on 3 weeks as our time frame, and mainly in order to capture those patients. Also because there are some data to suggest that the weight loss occurs at approximately a rate of about 2.5 kilograms a week for the first 4 to 6 weeks with these interventions. And then once you hit that quote unquote plateau, then it drops down to about 1 kilogram a week after that. And so we felt as though we were still getting a good amount of efficacy while also achieving some feasibility.
Is that sold over the counter in Canada?
Yeah, exactly. So it is to some degree. For the most part, it does require a prescription, though. It's a little. There's ways around it to get Optifast over the counter, but for the most part, the product that we used, MediMeal, it does require not necessarily a formal prescription, but essentially a referral from a physician to some degree. Yeah.
Ricardo, what about in Brazil? Is this sold over the counter, do these patients need a prescription for the very low energy diet?
No, Optifast is sold over the country. No problem.
Okay. And as compared to the new drugs, the injectable drugs, what are the differences in costs, Ricardo, in Brazil?
Oh, very much is cheaper. VLCG are very, very cheap compared to the new drugs.
Okay.
And despite that, the drugs in Brazil are less than half price of the North American price. So even though very low calorie diet here is cheaper. And Tyler, if you're interested in the field of obesity, tonight we have published at the Lancet a new definition of obesity. So we're moving away from BMI. We're moving away from anthropometrics to define obesity as a disease. We're going to call it, this is a teaser, clinical obesity and preclinical obesity. So this will be out in 2 hours, actually, in 2 hours and 30 minutes at the Lancet.com. So you could add in your paper this, because this will change the way we manage people with obesity.
I heard through the grapevine that this was coming, so I'm excited. I'll take a look.
It's tonight. Yeah, it's tonight. Yeah.
Awesome.
All right. I see there are no further questions. I think we have had a very interesting discussion. I want to thank you both
Indeed.
for connecting and sharing your data, Tyler. Congratulations on the study. We're looking forward to the RCT being published soon. And thank you, Ricardo, for the excellent points raised and the insights coming from such an important and prestigious individual in the field of obesity surgery. So thank you both very much. Thank you everyone for connecting. We will share the next session shortly with the social media channels, and again, this will be available in our YouTube channel. For those of you interested, please sign up for the YouTube channel and look at the discussion and recommend to your peers. Thanks again for everyone. Have a wonderful evening, and I'll see you next time. Bye, everyone. Bye.
Bye.
Thank you.
Thank you for watching. The published article discussed in this virtual session could be found at the address below. And for any other techniques in coloproctology content, you can visit the Springer website at link.springer.com/journal/10151. Be sure to subscribe to our Techniques in Coloproctology social media outlets, including YouTube, LinkedIn, and Twitter X. We look forward to seeing you at our next virtual session.